Yeah, please.
Yes, sorry about that. So I'll be presenting on the first 47 cases of DMEK and the transition from DSEC, no financial interest. So DMEK is now the standard of care for treating any endothelial pathologies. And it was introduced by Millies back in 2006 and has undergone a lot of changes. The current study aims to report the outcomes of the first 47 cases and look at the transitioning factors from DSEC. So 47 patients from September 2019 to July of 22 were taken. We looked at the visual acuity, cell density, and the complications, and compared with DSEC performed at the same point of time. Surgical technique, graft preparation by surgeon, and we are using an AR40 cartridge for the graft insertion, and inferior PI was done in all the cases. If you look at the demographics, 47 eyes of 45 patients were taken with at least 3 months of follow-up, more females. The average age of the patients was 61 plus minus 10 years. About 30% were triple procedures and the rest were DMEK alone. Indications, Fuchs alone was 21%, and then we have around another 20% of Fuchs in PBK in Fuchs. PBK for due to other causes was 47%. Rest miscellaneous causes were TAS, HSV, eyes, and failed DSEC. The vision improved from logMAR of 1.57 to logMAR of 0.3 in the over a period of 2 years, and the cell loss reported at 2 years was 39%. This is one of the cases. An intraoperative complication, graft detachment, was noted in 15% of the eyes, and rebubbling was done in 3 cases. The others resolved spontaneously. There was no instance of graft loss during preparation. 1 pupillary block which required anterior chamber formation on day 3, and 2 instances of graft extrusion while injection, but they could be retrieved from the conjunctival cul-de-sac. Post-operative, 2 episodes of graft rejections which resolved with steroids hiking them up. No graft failure till the current follow-up of the study period. The pre-op CMEs which were detected were given simultaneous posterior subtenonous injection of tricort, and post-op CME was detected in 3 eyes. 2 were treated with the PST injection and 1 with NSAID. Post-op glaucoma was detected in 10% of the eyes. Now coming to the transition from DSEC, so this I've divided as per the years. So in the first year almost it was 50-50, but then due to pandemic, I decided to go to the more DSEC, which was more predictable in my hands. And again, from the last year, again, transitioned more towards the DMEK. And if you look at the indications, this is where the 3 places where it's highlighted. One is Fuchs, almost entirely shifted to DMEK. Then PBK in FECD, again, almost shifted entirely to DMEK. PBK due to other cases was about 50-50 distribution. And finally, in the failed PK and failed therapeutic, it was mostly DSEC was done. The triple procedures again was similar in both the groups, 30% for DMEK and 23% in the DSEC. So even though it's a beginner case, the visual outcomes were comparable to other experienced DMEK surgeons. The indications and endothelial cell loss matched with prior reported from our centers. However, the Fuchs was considerably higher compared to the reports from rest of the country. The graft detachment again matched those of other learning phase surgeons from India and abroad. However, there were few more missed follow-ups during the pandemic period. So tips for transitioning, the learning curve from DSEC to DMEK can be made smoother with lots of wet lab tissue practice and also case selection. However, the limitation of the study is the short follow-up period in some of the later cases. Thank you very much.
For the cases with pseudophakic bullous keratopathy, you preferred DSEC versus those with Fuchs and PBK. Am I right?
Yes, so the indication and surgery is slightly modified due to the pandemic, because in between those 2 years, there was a tissue crunch. So I was preferring more to do DSEC because of predictable outcomes. So those intervening 2 years, the results, all the surgical technique is more skewed towards DSEC.
Did you see more scarring in the cases with PBK and Fuchs, pre-existing Fuchs, compared to only PBK? Was there a difference in the clinical presentation? Because the scarring would hinder visualization of the graph.
Yes, ma'am. So the scarring seen similar actually. The Fuchs patients actually tended to present earlier because the decompensation sort of happens earlier and they come early. So we could intervene also earlier rather than only PBK cases.
So more of edema and less scarring.
Yes,
So your
ma'am.
visualization was better.
Yes, ma'am.
Thank you.
Thank you, ma'am.
What are the recommendation you give regarding the case selection part? Which cases would be favorable for the DMEK as the DC?
So as beginner, I would recommend all patients with a good anterior chamber anatomy, you can definitely go for DMEK. And if you have good visualization, so less of scarring, go for DMEK. But for post therapeutic PK and post failed optical PK grafts, then better to go for DSEC because the graft attachment is more predictable.
And Dr. Basad, have you evaluated the surgical time between how much time you were taking in the initial days versus the
I
recent
actually
time
had a
showed?
slide, but for this I've
I
reduced.
think I missed that.
No,
Okay,
no, I have not presented
okay,
it.
so what do you think? I'm sure the surgical time would have reduced. And do you think
So
that has any impact on the
the
outcomes?
definitely initially the surgical time would be around for just without triple would be around 40 minutes. So now that has come to down to around 25 minutes.
So do you have a graph for that also, how your surgical time is improving?
I do not have it on this
Okay,
presentation.
I just want to
That is
know
a very
what
interesting
new
population you should
want to give the message to the what is the new things to what difficulties you overcome to
So only
transition.
two very important things to highlight is one is case selection. Go for the cases with good anterior chamber anatomy, and second is wet lab practice
And
before starting.
this is your transition from
Yes.
DSEC to DMEK
Yes,
only,
yes, sir.
nothing. Okay.